Good afternoon, everybody. Very warm welcome to our 2020 annual members meeting. And it's a little bit sad that we've got to do it like this, isn't it? Because it's one of my favourite events, actually, being able to have a quick chat with people before or during the meeting, finding out what you've liked about what we've done over the year and perhaps some of the things that you haven't liked so much. But we've got a great agenda today, and I sincerely hope you find it both informative and interesting. And it's great to have so many people joining us from so many walks of life and organisations. Just want to quickly flash up the agenda for today. We'll talk about the questions in a moment and then have a review of the year. And then what I think you'll find is a fascinating film about some reflections for COVID, a short film, and then 4 really, really powerful presentations to talk you through how we've been approaching COVID this year. Then we'll take a look at the accounts and the financial review, some news about our new governors and how they interact with the membership in general. And then very keen to allow some time for questions and answers at the end. As I said, we've been asking if you have any questions before the meeting, and some of you have sent some questions in, so thank you very much for those, and we've responded to some of those. In order to answer or to ask questions during the meeting, then if you wish to do so, visit Slido, the link below the video, or type Slido into your browser address and enter the event code 2222. But before we start, I would just like to say a few words of recognition, really. This calendar year has been spectacularly challenging, hasn't it, for all of us? The isolation, in some cases the grief, the strain on families, the economic uncertainty, and the very impact on our everyday normal lives, with still no clear end in sight. And yet, within the crisis, we've seen terrific moments of kindness, of humanity, of caring, of innovation and courage. And you'll see how some of that played out in the way the Trust has responded to the challenges during this evening's meeting. Now, though, I do want to take the opportunity, with your permission and on behalf of you, our members, to thank my executive colleagues on the board, led by our Chief Executive, Deborah Lee, for what they have contributed and accomplished this year. As Chair, I could not wish for a more talented, compassionate and committed group of individuals who, together with the support and challenge from non-executives, are leading this organisation. Moreover, though, they are joined by over 8,000 colleagues who have gone to extraordinary lengths to do their very best to care for those we serve in some very difficult situations. I take my hat off to you all and thank you from the bottom of my heart. I'd also like to take this opportunity to thank those who give of their time so instinctively as governors, and we'll talk a little bit about that later on. So moving into the agenda, I'm acknowledging the notes of the annual meeting that we had on the 12th of September 2019, and in seeking approval for those, for the correctness of those notes, would ask that if anybody has any comments to make, they send them in within 7 days of today. So thank you in advance of any notifications. So that's probably enough for me for the moment. Do enjoy the evening. And I'm now delighted to hand you over to Deborah Lee, our Chief Executive, to take us through our annual report.
Welcome, and thank you, Peter, for those words of acknowledgement. Of course, anyone that's stood in my shoes or a role similar to mine will know that one of the most important relationships for me is the one that I have with my chair, and I couldn't be more fortunate in the chair that I have. It's been a phenomenal year, as Peter has said, and we're going to spend some time now looking back on that. So what are my reflections on the year? Well, it has to start, doesn't it, with a recognition that it is a very different one to the one that I expected. It absolutely continues to be a privilege to lead the Trust and to serve the people of Gloucestershire, and I think never more so than having had the opportunity to preside over the organisation's response to the COVID pandemic. Whilst inevitably this evening, and for many of us, our memories of the year that's gone will be of the last few weeks of that year as we began to grapple with what was ahead of us. But it feels really important for me to acknowledge the 10 months or so that went before the pandemic hit, when we achieved such a lot. I remain in awe of the skills, the compassion and the dedication of my colleagues, and whilst without doubt working within the NHS is a hugely rewarding experience for the vast majority of us, it's also a really demanding place to work, and I have spent a lot of time reflecting on my role in ensuring that my colleagues, and indeed myself and my team, are in good shape, that our health and well-being is something that we all care about and that we take time to care for ourselves. But we're not a closed system either, are we? We're not just a hospital. We're a group of people who work with others. And again, the strength of the partnerships we've developed with colleagues throughout Gloucestershire came to the fore when the pandemic struck. We couldn't have worked the way we did, which I think was nothing short of magnificent, if we hadn't had those established relationships and the tremendous support from colleagues in the commissioning group, in Gloucestershire Health and Care Foundation Trust, in social care and indeed beyond and into the council. So what were our successes in 2019-20? Well, as I said, they were many and they were varied. We established our strategic objectives, and despite the way that the year ended, we made some really great progress against those. We were delighted to be awarded just shy of £40 million of capital to develop our 2 hospital sites, and also to have the opportunity to commence our digital journey with respect to our electronic patient record. We completed our Fit for the Future engagement programme. I'm going to hear some more about that, but we had a phenomenal number of conversations and contacts with many of you that are listening and viewing this evening to inform the shortlisted options that we will be taking forward, hopefully into public consultation later this year. There were many firsts for the organisation. One of the things I'm particularly proud of is that quite often I find myself saying we're one of a handful of trusts who have achieved something that the vast majority haven't. And one of those things this year was to be invited to be one of just 14 trusts to take part in a national pilot programme called Pathway to Excellence, which is aimed particularly in supporting our 2,000-strong nursing workforce to excel in the care that they provide to you. The other thing that I'm particularly proud of is how we are developing our approach to delivering really great care and getting more and more nuanced and sophisticated in that approach. It sounds posh, it's a posh title, isn't it? Human Factors Faculty. But this is really about helping us to understand what it is about us as human beings, about our behaviours and our very nature that impacts on the way we approach care. We also continued with our national staff survey, and I've talked at length about what it's like to walk in the shoes of my colleagues, and we all try to really understand what it's like to be somebody that works in this organisation, to be a colleague. And I was really delighted, therefore, in this year's survey to note that 3.4 percentage point increases were seen in the proportion of staff that recommended the trust as a place to work. I've touched on our health and well-being. It's at the very core of what we are about as we go forward with the next year in particular. And we launched in the last year our Health and Wellbeing Hub, and huge thanks to Emma Wood, my Director of People, who led that initiative, but equally so to those that have worked in the Hub in what has been an incredibly challenging year. But around 43% of our workforce reached out to have a conversation with the Hub in search of support. Progression of our diversity inclusion agenda has probably taken on much more pace in the last 6 months than perhaps it had in the year that we're reflecting on. But 40% of members, we grew the membership of our diversity network by 40%, which I think just gives a sense of we were already beginning to recognise the importance of developing this agenda. And one of the phrases that I've used recently is that diversity, it's a fact. We are or we aren't diverse, but we have a choice about whether we're inclusive. And I think we've moved our work forward very much with that at the centre of our thinking. We started our Big Green Conversation. As a trust, we were one of the few, again, to declare a climate emergency. That was our way of signalling how much this agenda matters to us. We launched a number of successful appeals, and we, in record time, raised £2.4 million from our local community to fund scanners that are now in use and were particularly timely in respect of the last 6 or 9 months that we've been through. And of course, I could stand here for much, much longer if I described the numerous national, regional and local awards that our staff have won. Couldn't be more proud. And if you've travelled this journey with me for 4 years, it might seem odd that the final bullet on these 2 very busy slides is just to acknowledge that we delivered our financial plan, indeed with a very small surplus. Who'd have thought when I stood here in my first meeting, I'm just trying to think, I think, Craig, I'm going to look at you, 3 months after I arrived, I delivered my first address as Chief Executive in a trust that had just announced a deterioration of around £40 million in its financial position. So maybe I should have started there, but I'm certainly delighted to have the chance to end there. So what would we have liked to have done better? You know, we are an organisation devoted to improvement, and I would be the first to acknowledge that we don't get it right all of the time. What I do believe, however, is that we are candid, open and honest about those occasions, and that we are absolutely committed to ensuring that no experience that's anything less than positive is a wasted experience, and therefore that we learn from it. What we do know is that some of our colleagues do report a less positive experience of working in this organisation. They're likely to be colleagues who come from our Black, Asian and minority ethnic communities, or they may be colleagues who recognise themselves as disabled. That's not right, it's not good enough, and it has to change. Our teams tell us that on occasions it's still too difficult to sort the simplest of things, and I, as Chief Executive, often these things float to the top. I don't know if they float to the top, perhaps they just come into the top, but many of these things land in my inbox, and I'm really, really sorry when these emails land, but always do my best to work with my team to make sure that we don't just fix it for the moment, that we fix it for good. We had great ambitions for our waiting times in cancer treatment, and my goodness, we did phenomenally well. But we didn't improve in urology to the extent that we wanted to. And you'll see there, but, there's a but and a ... and I'm going to come on to that in a moment. Too many patients continue to experience delays in their discharge from hospitals, and on occasions, patients and their families raise concerns about the quality of that discharge. First impressions matter, but also last impressions matter, and we need to do better than we've done on all occasions this year. Communication couldn't be more important. We've seen, haven't we, the power and the importance of really good communication during the pandemic, and I would be the first to acknowledge that my personal communications, but some of our corporate communications and our communications to you as colleagues and members of staff have not been as clear or as timely as we might have liked them to be, and again, that's the focus for the coming year. And we continue to be challenged in terms of recruiting some of our long-standing vacancies, particularly in medicine. But again, we've got that but and the ... and I'll just follow on there to say, but however, care of the elderly is one of my kind of index measures. It's my specialty that really tells me how we're doing when it comes to recruitment. We've had such long-standing, protracted, intransigent vacancies in that specialty, and we have recruited this year, so not in the year we're talking about, we've recruited this year for simply outstanding care of the elderly consultants who are going to come and work with us. Some have started, I've met them all now, and they are the most inspiring group of individuals, and that specialty will go from strength to strength. And of course, if there's a group of patients in this organisation that deserve the very, very best, it's the group that they will care for. So welcome, if any of you are watching this evening. And look, let's just spend a moment on the urology story and cancer waiting times. When I arrived in 2016, we were already 2 years into an improvement notice because we were struggling to deliver timely cancer care. And we made tremendous improvements in the last 3 or 4 years, to the point that a year ago we were achieving the national standards in all but urology when it came to the waiting time from the point that somebody refers you to our service and the point at which we commence your definitive, hopefully curative treatment. But urology was, we were stuck. We were really, really struggling to improve. And there are too many people to mention, but I can't not acknowledge the work of just a few in this area. Felicity Taylor will be mortified at the mention of her name, because she is the most modest leader that I've probably ever worked with. But Felicity, supported by her director, Rachel Decaux, have driven this. there's another really modest individual called James Curtis, who has made this his life's work. And the way in which that team have worked with clinical colleagues in the urology service, but importantly, for this improvement phase, with colleagues in diagnostics, in radiology, in pathology, in other areas, to redesign the way we deliver care, and particularly for prostate care, which is the predominance of care within urology. And I hope that these charts speak for themselves. If the graph is going in a good direction, that's a good thing. So you'll see there that the days waited from referral to decision to treat has gone from us being the worst performing organisation in the Southwest to one of the best, not just in the Southwest, we are the best in the Southwest, to one of the best nationally. And similarly, you can see there the days waited for treatment in other bits of that pathway. And we've achieved that in the last few months, and not because, as somebody asked me, we've got fewer patients in those pathways, far from it, but because we have designed, redesigned, examined forensically every step of that pathway, and that, I believe, is now an embedded change. So what are our current challenges? Well, as you might imagine, they link very closely to the priorities that I'm going to focus on for the last slide or two. But the pandemic had a huge effect, didn't it, on us all, on our lives. And without doubt, the biggest challenge that I face as I look out as a leader into the next year is the challenge of restoring the services that were paused or indeed even ceased during the pandemic, whilst also being ever mindful that winter is ahead and that we can expect a further surge in the virus. Hopefully, not of the order we saw first time, but nevertheless being prepared. And of course, as I've alluded to, there is a legacy to the pandemic. Some of us will bear that legacy very personally, but there's a legacy on the health needs of patients. We know we have very large numbers of patients now waiting for routine care, which, given the efforts of the last 2 or 3 years to eliminate those backlogs and those long waits, that's really difficult. It's really disheartening for my colleagues, particularly my clinical colleagues, to look out at their waiting list and see patients for whom they cannot deliver the standard of care that they want to. And of course, it hasn't ended, has it? We are still operating in the context of a virus that's circulating and potentially will increase. And that means that we are not able to deliver as much care as we have done previously in order to make sure that we are COVID secure, I think is the language. And you'll know what that means. It means that our colleagues, when they're caring for patients, wear masks. We have to clean in different ways. We're socially distanced. We can't have as many patients in our waiting rooms, in our clinics, in our theatres. So not only do we have backlogs, but we can't be as productive as we'd like to be. The financial framework is challenging, but I have to pay respects and thanks to the extent to which government supported the NHS in the first wave of the pandemic. At no single time did I stop to think about whether I could afford to do the right thing for a patient or a colleague, and I'm immensely grateful that that wasn't a pressure that I felt I faced as a leader. But it is challenging, resources are finite, and as we go forward, we will have to move back into living within our means, where finance is, rightly so, a key consideration. And of course, as I've talked about legacy, I've talked about challenge. You know, we have a workforce who is understandably characterised by groups of people, individuals who are fatigued. It took its toll. I've got colleagues in this room who wore PPE in the heat of May and June for 12, 14 hours at a time, giving us of their best. We had colleagues who worked on the basis of a set number of hours that they would work in a year. They gave us those hours in 3 or 4 months of a year. And people are anxious. They're anxious for the future, they're anxious for the here and now. And so one of our huge challenges going forward is how do we maintain a workforce who feel valued, who are resilient, and are equipped to deliver our vision of best care for everyone. So those challenges convert into a number of priorities for the years ahead, and I'll just pick out a couple of those there. One of the things that's very important to me is that we recognise that it's a favourite phrase of mine, forgive me because I think the chairman's getting a little tired of it, but whilst we were in the same storm, we were in different boats. And what that means is that some of our population was impacted differently to others, If you started with a degree of inequality because of your personal circumstances, your wealth, your housing, your education, then COVID, sadly, has probably worsened all of those things that were already impacting on your health. So we need a really nuanced and targeted approach to our recovery that makes sure that those that need healthcare the most get it first. But there were silver linings, weren't there? And I've heard staff talk about the guilt that they feel for talking about the positives that came out of COVID. I had a very personal positive. My children came to work with me every day for 5 months, and I travel an hour plus each way, and I felt I got to know them in the 5 months of the pandemic in a way that I hadn't before. Some of the silver linings were related to our professional environment. People work from home. We learned how to deliver care virtually almost overnight. And patients said that they liked it. They liked not having to drive to a hospital feeling anxious, looking to park and then paying to park and then trying to find the department. They liked the conversation they were able to have over the telephone. So we want to embed these changes, and we've talked as a board just today about our focus on ensuring that we make it easy for colleagues to give of their very best, that compassionate care, compassionate leadership is the culture that we're known and recognised for, that everyone can come to work without fear of discrimination and where they can thrive and can fulfil all of their ambitions. We do want to make further progress on waiting times, and notably cancer, but we're there. The challenge is just to hang on, keep it, maintain it, and I'm really confident we will. We've got some really exciting developments in our electronic patient record programme that served us so well, didn't they? In the peak of the pandemic, when we held our nerve and we mobilised aspects of that programme, it kept patients safer at a time when we didn't need it more. And so finally, for me, it feels almost like a singular priority. It sits above all of those, is how I lead an organisation and work with all of you in a way that you believe that my most important responsibility is to look after your health and well-being so that you can care for others. We're going to try and capture some of that year that's just gone in a short video. It's around 9 or 10 minutes, I think, Craig. And I'm going to say reach for a tissue. I've seen it a couple of times, and on each occasion I have been so incredibly moved by it. And this is real stuff. This isn't people we filmed to make this. This is a montage of things that happened, things that people said, recordings that we took during the time. So please enjoy it. And when that's over, we'll welcome Dr. Steve Twigg to speak to you about some of his personal experience as somebody at the front line of COVID care. Thank you.
There are now more than 118,000 cases in 114 countries. We have therefore made the assessment that COVID-19 can be characterized as a pandemic.
The coronavirus is the biggest threat this country has faced for decades.
This is a message from nurses in Gloucestershire hospitals. Please stay at home.
We are prepared for this. We have rehearsed this, albeit not of this scale. None of us have experienced something like the times ahead. We're going to all have to work differently over the coming weeks and months. Clinical staff are going to need to be upskilled in the care of patients with respiratory illness.
The time has now come for us all to do more. You must stay at home. I want to thank everyone who is working flat out to beat the virus. Everyone from the supermarket staff to the transport workers to the carers to the nurses and doctors on the front line.
There are indications that the measures that we put in place have been successful in slowing down the spread of this virus.
We are planned, we are prepared. The amazing amount of work that people have done, we've flipped this trust in about 3 weeks. However busy we are today, we're going to be at least twice as busy in 7 days' time, and that's what we need to expect.
What is it like, this turbulent time in the trials of COVID-19? while your family and friends are hidden away, nowhere to be seen.
It came without warning from faraway lands, with no respect for our own personal plans. We do our jobs with kindness, respect and with care. Wearing uncomfortable PPE, you can hardly get air.
When we get to the edge, we will be ready. When it's time to jump, we will fly. We've got this.
Walking away from someone that you love who's very, very unwell and driving home at 1 o'clock in the morning, really, really upset and not getting a wink of sleep because you're waiting for the phone to go.
We should take comfort that while we may have more still to endure, better days will return. We will be with our friends again. We will be with our families again. We will meet again.
The supportive care team is being put together now and will hopefully be contacting you and your pods in the next few days.
We cannot take away the distress of not being with loved ones at the end of their lives.
But we can do everything in our power to never forget.
Every name is a person.
Every person is a life lived.
Every life a story behind it.
Whilst we may have little time to get to know each person,
we will provide comfort and endeavour to ensure that they are not alone in their final moments.
Some of our staff are actually superheroes underneath too.
I don't see it as being courageous. Every year that I've been a nurse, I've done the same thing. This is no different. It is scary, it is frightening, but we would all just make the decision to just do our job.
I'm immensely proud working for the NHS and doing what I do on a day-to-day basis. In the morning, we feel fear and anxiety like everyone else. It's a new normal for us in this pandemic. Fear and apprehension is not a sign of weakness. It's what makes us human.
We are now making progress in this incredible national battle. I've seen the personal courage, not just of the doctors and nurses, but of everyone. The cleaners, the cooks, the healthcare workers of every description, physios, radiographers, pharmacists, who've kept coming to work. It is thanks to that courage, that devotion, that duty, and that love that our NHS has been unbeatable.
Thank you for supporting our mums, babies and families in Gloucestershire.
With transmission significantly lower, we must stay alert, control the virus and save lives.
When I think of the innovation, the professionalism and the compassion that a Gloucestershire nurse has, I'm really proud to count myself amongst you.
Thank you for your skill, your talent, your kindness and your compassion. Today, we're celebrating each other.
Even with COVID, normal illness exists. If you're worried, the NHS is here for you.
One of the things that's really touched me is our community support. We have engineers, entrepreneurs, all sorts of people in the community in Gloucestershire who have been supporting us, and it's just truly incredible.
And they've done the most remarkable things. You can tell by all the people coming out every week to clap.
I don't think we can say thank you often enough to our volunteers for all that you do.
Over the coming months, people will still see personal protective equipment as a key piece of their armoury in terms of keeping themselves safe, but also the patients safe.
How do we pause and take a moment to commemorate, remember that we as staff have gone through quite a difficult few months, and we want to remember those lives that were lost, and we want to remember those lives that were saved.
Many of the requests that we're facing at the moment are labour intensive, and as such we need to have the flexibility to put the staff where the workload is.
Face coverings should be mandatory, giving people more confidence to go on public transport and to a hospital setting when they need to.
It's been a marvellous opportunity just to have a chance of seeing people who I know have been doing so much literally on the front line.
We couldn't have done it without you, so I just want to take the opportunity to thank you and to wish you well with the celebrations of our annual Healthcare Assistance Day. Thank you all so very much.
As we continue to face the biggest challenge the NHS has faced in its 72-year history, it's right to pause and reflect and recognise the tremendous commitment and dedication by all our colleagues that have cared for patients and carers and families so well during these very difficult times. I would like to thank all staff
for everything that they do and wish us all a very happy 72nd birthday.
Happy birthday, NHS!
The way they've looked after people, the way they've sort of kept control of the whole thing, you know, it's a question of not panicking, getting on with it. They are Britain at its best.
Being a volunteer is all about giving. And you give so much. You give your time, your energies, your gifts, your love, very often your emotion as well.
Something would happen that we weren't expecting and we responded. And it's just an amazing testament to the team here, what we've done over the last few months.
Gloucestershire's response to the pandemic was nothing short of magnificent and touched all of our lives in different ways. We suffered the same storm, but often in different boats. A year like no other, unexpected and unprecedented. A year when I couldn't be more proud to be part of the Gloucestershire health and care system. I couldn't be more indebted to my colleagues for their individual contributions or to their families for supporting them, or indeed more grateful for the extraordinary shows of affection and support from our local communities. We go forward knowing what we are capable of, having learnt lessons from the first phase and having become closer as both friends and colleagues. Whilst we may not be clapped on a Thursday evening, let's not forget that we've still got this.
Well, I hope you enjoyed that very moving film, which does describe a lot of the things going on in the hospital in the last few months. My name's Steve Twigg. I'm one of the consultants in anaesthetics and intensive care at the hospital. I'm also the specialty director for anaesthetics and critical care. What I'm going to do in the next couple of minutes is just put a bit of meat on the bones of those sentiments about the COVID crisis from my perspective, talk about the medical response to the COVID pandemic, particularly how it affects those that are affected most seriously ill, which are the ones that ended up in critical care, otherwise known as intensive care. I'm going to start by just going through the how rapidly things progressed from when we learned earlier in the year, talk a little bit about the number of patients that we treated in intensive care, what happened to them, and then how we reorganised virtually the whole hospital in order to cope with the overwhelming number of patients that were coming in during this time. And then I can't really leave without touching on what might be a second surge and what the hospital is doing at the moment to prepare for the winter ahead, as Deborah said. We've already seen in that film that COVID-19 was invented on New Year's Eve last year, so I'm sure you'll all cast your mind back to what you're doing on New Year's Eve, and I think the phrase socially distanced probably wasn't one of the things on your lips at that time. It then rapidly spread through China into Europe, and the first cases were seen in Northern Europe in early February. Our first case in Britain was in February, and really within a very small number of weeks, sporadic outbreaks happened all over northern Italy and into the rest of the world. In this country, the major urban conurbations were affected worse, and London particularly around mid-March was showing a increasing spike of cases. So all throughout the country, there was a rapid upscaling. You'll remember this from the news reports about ITU provision, the number of intensive care beds, and particularly things like the number of ventilators that the country had available to treat people. And there really was a huge uncertainty during that time about whether the country had enough equipment to do this. And in the context of this, the trust, as every trust in the country was doing its utmost to mitigate these, at that time, unknown risks. And it was a really quite an uncertain time for everybody, particularly obviously us in the intensive care world. It was a national challenge, and that actually does have some other issues in that everybody was going after the same resources. Everybody wanted to up-provision ventilators, buy some more ventilators. People who installed intensive care pipeline on new ITUs were in very short supply, so we really had to be very creative in how we responded. And I'm immensely proud about the staff in the trust who were able to work around all these challenges and were able to establish an increased provision for these services during the months of March and April. I've got a few graphs to show you. This one really is just of the how the pandemic in the first wave affected those of us in the southwest. So for the purposes of this slide, this is from Gloucester through Swindon, Bristol, all the way down to the peninsula, down to the end of Cornwall. So this is the number of cases, and you can see from that we're peaking at about 500 cases roughly at the start of May, but this first pandemic surge spreads really from the start of March to the end of June, and that really puts into context where we were in the southwest. Unfortunately, Gloucester was leading the way for a number of reasons, which I'm sure many of you will know about. Gloucestershire was affected very badly by the first wave. On this slide, you'll be able to see the light blue line is the number of cases up to July, with Gloucestershire being significantly the biggest, having the biggest effect on number of cases in Gloucestershire compared with Bristol, Somerset and Wiltshire. The green bar on that graph just shows you the cases since then. This was numbers to the end of September, so you can see that the numbers have been steadily rising, but really the first wave was what hit Gloucestershire quite badly. In terms of our ITUs, so you will know, if you know a little about the hospital, we have a large ITU in Cheltenham, a large ITU in Gloucester and a smaller high dependency unit in Gloucester hospitals. So we normally have 3 intensive care areas that we normally man. Our surge for COVID patients during the first surge really peaked around Easter Sunday, where we had 36 patients. This graph, the green line, represents our normal absolute maximum capacity of intensive care patients, and you can see that we would double that for many, many weeks over the COVID surge, peaking on about Easter Sunday. At this point, we had 6 separate intensive care areas manned, with nursing, medical staff and equipment, 2 in Cheltenham and 4 in Gloucester. And as you can see, that's double our normal capacity. So how many patients did we see in intensive care? In total, across Gloucestershire, for the first surge, we saw 88 admissions, which was 77 patients. So 11 patients came to our unit twice. They got readmitted. We had a good outcome with 50 alive, and unfortunately, we had 22 deaths in intensive care. If we compare that to our colleagues in the region, so those in the southwest, we had a survival rate of about 75%, compared with favorably with about 67% for the southwest region as a whole, and nationally the figures are around 58%. So we like to think that we performed a reasonable task at getting the numbers and looking after the people of Gloucestershire in the best way in our intensive care units. So how did we do this? We've already alluded to the fact that we had to cancel elective operations. We needed the staff, we needed the nurses, we needed the doctors, and we needed the equipment from the operating theatres to man up these ITUs over a very short number of weeks during March and into April. However, we did continue all emergency operating, and we continued the vast majority of cancer cases, such that in fact some of our cancer waiting lists actually went down during the COVID period because we were able to carry on operating in a very effective manner in some of our operating theatres. This is unlike a lot of trusts around the country who actually stopped all elective operating completely. So we had to clear wards. We got some help from the independent sector, so we took over hospitals, the Winfield and the Nuffield private hospitals, and they looked after and nursed for patients with both COVID and non-COVID disease. Unfortunately, we had to stop patient visiting, and this provided some very interesting challenges, particularly in intensive care, and particularly when people, unfortunately, were reaching the end of their life. Dr. Hellier, who's speaking after me, will provide a little more information about how we supported those patients and those relatives. We had to suspend staff leave for some time, obviously, to be able to cope with the increased ask on the doctors and nurses. And there was a massive redeployment of all staff, really, of medical and nursing staff and all staff in the trust, with people adopting roles that they maybe wouldn't normally do outside of the pandemic situation. And in order to make this safe and effective, we formed doctors into different pods or teams of working, which allowed people to act safely in areas that maybe not their normal working practice, but it allowed us to cope with this overwhelming tsunami of patients coming to the trust. In terms of intensive care, we had to upstaff our doctor provision by 2.5 times. We had a consultant presence on the ground in intensive care and in the operating theatres 24 hours a day, and our nursing numbers had to be increased by up to 4 times, and this was really by using staff from the ward, both nurses, doctors, and in quite a lot of cases, consultants working as nurses in intensive care. In terms of the physical environment, over the 2 weeks of the pandemic, we managed to increase our ITU capacity from normally around 18-20 beds up to 56, and we had very effective, well-laid plans to go up to 91 should that need arise. And we turned our 3 ITU areas I've already described up to 12 potential ITU areas, of which 6 were used. These are areas adjacent to the intensive care units, usually operating theatres, recovery areas from theatre or adjacent wards. Equipment-wise, I've already alluded to the fact that ventilators were a major problem in terms of availability. Now, as we come into the winter, we do have an increased availability of intensive care ventilators, but at this time we had to reuse anaesthetic machines and machines designed for operations in the intensive care unit. And also, you'll be aware that during this time, PPE, personal protective equipment, was in quite short supply around the country in many areas. We had no problem in this county, and we used these reusable yellow gowns that you can see on the screen, which were reusable, so we didn't run out of those bits of equipment. So just to finish off, what about the next phase, the second surge? This slide, unfortunately, is quite a bit out of date, and the numbers for the Southwest now, you'll see on the right of the screen, that line is now, as of today, gone above the numbers as of the first surge, which is on the left. So we're definitely entering a second surge. We don't feel it's going to be as a rapid onset as the first surge, and we don't feel the intensity of it will be as much, but we'll have to wait and see. We are definitely prepared. We have the knowledge from last time, what we learnt as an organisation to move our staff and our equipment around. We've learnt how better to look after patients. We're involved as a trust in the research trials into drugs that have been used in treating COVID disease, particularly things like dexamethasone and remdesivir, which we were involved in research trials about and which we use in the hospital today. And we can assure patients of Gloucester that every patient that comes into our doors will receive the best possible care within the trust. We will, this time, hope to able to continue all emergency and elective work as well. Deborah's already talked about this and the fact that we've been able to separate our hospitals to focus care on 2 separate sites, in Cheltenham, a centre of excellence for elective and cancer surgery, and in Gloucester for emergency and COVID working in Gloucester Royal. So I'm going to stop there. I'm immensely proud of all of the staff throughout the whole trust who went above and beyond to make this change happen over an extremely short space of time. And personally, it was something that is very humbling to be part of. I'm going to hand you over now to Dr. Kate Hellier, consultant stroke physician, and she's the Chief of Service for Diagnostics and Specialities, and she's going to talk a little bit about the end-of-life care during the COVID response.
Thanks, Steve. So I wanted to begin really just to setting the scene as to how we managed in the hospital preparing for end-of-life care and how we provided the care that we felt was needed for our patients. We knew that as COVID was approaching, that not everyone would survive. As you've just heard, visiting to the hospitals was limited to protect the patients, the relatives and the staff. And we needed to ensure that if any people died of COVID, that they would receive the care and respect they needed, while understanding that we would be caring for patients in a very different way. Dr. Emma Husbands, one of our palliative care consultants, helped create Every Name a Person. And this was our pledge that every person who died would be valued and treated with dignity. We were all watching the news and reading the papers as the pandemic swept towards us. One of my best friends happens to be a doctor in northern Italy, and so I was talking to her daily in the weeks leading up to the COVID pandemic hitting here, and she was sharing her experiences of what she was going through. She described the huge number of deaths that they were experiencing, and she described more deaths there in 2 weeks than they would normally have seen in an entire year. At work, I was fortunate to be part of the team helping prepare the hospitals. And as we started to create areas for groups of patients, which we called pods, it was clear that we needed to have areas skilled for both acutely ill patients, patients recovering, as well as areas for end-of-life care. We worked 3 days on, 3 days off, 12-hour days. All our leave was cancelled. Weekends were essentially cancelled. It didn't matter what day you were working, you just worked it without fail. Within the pods, we created teams of all staff groups. And as Steve's already said, we redeployed staff from areas where they wouldn't normally have worked to come up and work on the wards to help us look after the patients in the best possible way. We made sure that every area, every pod, had medical consultants in charge, people that knew what they were doing, that could look after the patients in the way that they needed. But we also ended up having a variety of staff that wouldn't normally have been on the wards with us. In my pod, we actually had a group of orthopaedic consultants as our junior doctors, which was quite an interesting role, but one that they rose to the challenge and were absolutely a vital part of our team. In my role, my day job, I'm a stroke consultant. I'm trained as a consultant in elderly care. And so I knew that I needed to go and help on one of the palliative pods. My husband, Simon's also a consultant here, and he went to one of the acute pods. We started working with our 3 days on, 3 days off. However, on Simon's pod, one of his consultants was self-isolating. And so he did 6 long days straight off. And on day 7, he became symptomatic with COVID. The morning, I had to get out of the house as fast as I could, because that meant that I could carry on working, and I knew there was no choice. But leaving my husband home in the spare room, ill, with all that we knew is that patients around the world were dying of COVID, and medical and nursing staff were dying, we had no idea what was going to happen. I've got 3 kids, this is them there, and they were brilliant. And my daughter ran the house for 2 weeks while I was away, looking after not only her younger brothers, who vaguely helped. She was washing, cooking, cleaning, realising the jobs that mothers do all the time. But she also had essentially a poorly father up in the spare room that she had no idea how he was doing. And she had an absent mother who was at work trying to get on and look after the patients. This photo is taken when we got home. This was one of our allowed days out, and I tell you, it was an amazing day. So coming to the patients, this is what we were all there for. We knew that visiting restrictions meant that relatives couldn't come in to be with the patients. We wanted to be able to let the relatives know that their loved ones were being cared for and that they were comfortable. This was so different to how we previously had managed end-of-life care. It was nothing like we'd ever experienced. Being able to hold a hand or even hug someone in distress is such an important part of providing care at such times. But COVID would not allow that. We knew that we needed to communicate in different ways. And so as well as our daily ward rounds, looking after the patients, making sure they were on the right treatments, making sure that they were well cared for, a massive part of our role, particularly on the palliative pod, was getting in touch with the families, phoning them, videoing them, making sure that they knew that their loved ones were being well cared for. I want to share with you some examples of what we did. One of the really hard parts was breaking news over the phone that someone was dying. In hospital, we're usually able to recognise that someone is dying, and we can call families into the hospital and we have that conversation face to face. However, with COVID, we couldn't do that. On one occasion, I told a lady that her husband was dying, and not surprisingly, she broke down and was sobbing on the phone. I was trying to comfort her, but when I asked if she had any friends or family that could be with her, she told me that no, she was self-isolating in case she too had COVID, and no one was allowed to visit her for the coming days. So she had to go through the death of her husband all alone. This was really hard to feel her pain, but obviously we kept the conversations going as best we could over the phone and over the video. As I drove home each evening, I'd often think about patients under my care. I do that now, I think we all do. But I remember one evening I was going home feeling really worried, because while I was holding the video up to a patient and the family was saying goodbye, the patient started coughing uncontrollably. I was really worried as I drove home that this was their last image of their loved one, and I just thought that's just such an image that I wouldn't want to experience if it was my loved one. When I came back in the next day, the patient was still alive. And so one of the first things I did was rapidly rally round the whole family and get them back on the video to see their relative much more at peace. And they passed away later that day. Some patients were with us for several days, and we were able to facilitate many conversations with families. One gentleman had several relatives, and while he was with us, we were able to arrange many calls with the family and with him. But it was a very different experience there to be holding an iPad while families were having these calls and saying farewell. It was also hard if the patients were forgetful and couldn't actually remember why they were here, and particularly why their relatives weren't with them in person. But we did what we could. I'm incredibly proud of our response, and I'm so fortunate that I had the team around us that we did. We had doctors, as I said, from every specialty. We had nurses from multiple areas, sometimes nurses that normally would have been in outpatient areas, coming up to the wards and looking after these patients. The domestics, the porters, the ward clerks, everyone was vital, and it was a brilliant team. We were witnessing the amazing public support with the claps for carers, but it was hard. The emotional toll. One of my junior doctors, when we first started the video calling, we were working out who was going to do the calls each day. And as we got to the end of the day, we had 3 calls still lined up to do. And she volunteered. She said, "I want to do it, let me." And that was fine. And so she went on and did the calls. And when I came to her the next morning and asked her how it had all gone, she was just saying how she found it so hard, and she didn't realise how hard she would find it, and how she'd had to go into a quiet room and just cry because she just didn't think that this was something she'd have to do. She'd only been qualified for 6 months. I've been qualified for over 25 years, and I've worked 100-hour weeks when I was a junior doctor. But this is the hardest period of work I think I've ever experienced. I still think about the individual patients and their relatives, and I feel proud that we provided the care that we did. We looked after everyone as best we could. But it's not over. We know that the COVID rates are increasing. We know that more is coming. And what we need everyone to do is to follow the government guidance, hands, face, space. Let's see if we can keep the numbers down. Let's keep looking after our patients as best we can and protecting each other. Thank you. I'm now going to pass on to Emma, who's going to come and talk about what was done for the staff. Thank you.
Thank you, Kate, and thank you for really sharing some personal stories there. I know it's quite difficult, so appreciate it. So I'm going to talk to you a little bit about staff wellbeing. So to start with, we have what's called the 2020 Staff Advice and Support Hub, and we developed this in May of 2019. And at the time, our ambition was to try to better support our colleagues with their physical health and wellbeing, their mental health and well-being, and also their financial health and well-being. So it had 3 strands to it. And at the time, the ambition very much was to create a single service, a bit like a one-stop shop, where people could phone 2020, email, get an appointment to come and visit a member of the team to better understand the needs that they had, and for us to signpost to them things that they may be required to enable them to be a little bit healthier. So initially, part of the ambition of the 2020 Hub was that we would help staff with absence related to musculoskeletal issues. So we would have fast-track physio, and that we would offer some online support, some telephone counselling, and some face-to-face counselling for staff who were off with mental health issues. And they, at the time, in 2019, were the 2 main issues for absence. What we wanted to do was really make it easier for staff then to understand the pathways and all the solutions that we had as a trust available to them and for them. So rather than them hunting around trying to find what the best solution would be, they could just go to a single place. What we didn't know when we launched the 2020 Hub in May with 2 staff members, Michelle Pashley and Emily Hoddy, was that COVID would happen and that we would actually have a hub that became a real lifeline for many of our colleagues. During COVID, we saw over 5,600 contacts, and to put in context, we have 8,000 staff. So over 5,500 staff contacted the hub. We went from a 5-day service to a 7-day service, 7:30 in the morning till 10 o'clock at night, answering calls for staff, helping with accommodation, helping to get people to understand what was happening with schools, childcare, what the latest advice was on isolation, quarantine. We also did things like send fruit baskets to staff who maybe left hospital having had COVID themselves. We called the 220 shielders, people that had a letter dropped on their door one day to say, you can't actually leave your house for 4 months. We called every single person, making sure that they were okay. We also started to really explain to people that it was okay not to be okay. And we ensured that we had lots of extra well-being available for staff. There was lots of self-care apps for people to use, whether that was to help them calm and meditate at the end of the day, to sleep. There were phone lines, there were different support mechanisms in place, 24/7, 365, that people could access in their hour of need. And I think it's a real reflection for me now around the hub that I don't know what we would have done without it. So whilst we started it in May, just to be really a one-stop shop for health and well-being, it became a lifeline to many of our colleagues. What also became a lifeline to our colleagues during COVID was the enormous amount of community support that we received as a trust. And I just wanted to take this opportunity to say thank you on behalf of the board for all the donations. We had so many people offer us so many things. Boost bags, which were bags that we would send out to our colleagues at the end of a shift. And when I speak to our colleagues, they tell me these sorts of things. And I've been asked today to really thank you, the community, for what you've given us. So they said, thank you for the cold drinks. So thank you for recognising that we sat in PPE for 12 hours in really hot weather and we were thirsty, and a cold drink was absolutely amazing in that moment. Thank you for laundry bags, shower kits, for recognising that at the end of the day we needed to shower, bag up our clothes so that we didn't take them home to our families and our children. Thank you for the pre-made meals and the offers of food, because we had staff who, as Kate has said, were exhausted, and actually having meals to take home was a real benefit. Thank you for your monetary donations, which bought us restrooms, extra chairs, and places where really tired staff could go and rest and have a moment to themselves. The wobble rooms. We had wobble rooms that we created where staff could go, as Kate described, and just have their own moment of reflection and tears if that was what they needed to do. So thank you, everybody. Thank you for Gloucestershire for everything that you donated to the charity, and for the charity who really worked incredibly hard during those months to make sure that staff got the things that they needed at the time and in the place that they needed. So thank you very much. So what did we learn then about COVID and for our staff? We learnt obviously that it was a really difficult time for our staff, and that in terms of our own behaviours in the organisation, we showed enormous compassion to our patients, which I hope has been evident through this evening's presentations. But we were also really kind to one another, and that really went a very long way in difficult times. The other things we learnt during COVID was that to be able to say, I'm not okay, was really important, and that we needed to make sure that we continued to have those conversations with our staff. Are you okay? The ask twice is what we call it. Having conversations on how you are. And we're spending quite a lot of time now thinking and focusing on how we develop our leaders and managers to really make sure that those well-being conversations are a part of our everyday contact with our colleagues, that we don't lose that compassion as we move forward. We also discovered and knew, and the science told us, that COVID had a disproportionate impact on our BAME communities. And for us, with nearly 16% of our staff coming from BAME backgrounds, we really had to stop and think about how we ensured that we had support and services in place to help those individuals who were feeling more stress and more distress than maybe our other colleagues. So we have thought very carefully about what sort of additional support we could use and have in place for our inclusion agenda. So we've got a BAME Equality Diversity lead who now helps us to understand, connect better with our communities and with our staff around what they need. We're launching Quell, which is a fantastic digital online counselling service, which is used nationally, but is known to be extremely popular across our BAME communities. So we're launching that just to provide an additional tool that people may access. We understood that the need for staff to decompress, for staff to talk about their experiences, was absolutely fundamental for recovery. So we have psychological link workers now that are working within the Trust who are going to different groups of staff and different teams to understand what it was like for them, to let them just release and reflect. We also know that we have a legacy issue. We hear about the legacy issue of having had COVID, and I think there's a legacy issue for having worked in a hospital when there has been COVID. And when we surveyed our staff, over 58% said, we think we're going to need psychological support now or in the future. So as we go forward, we're very mindful as a Trust that we need to make sure that we have absolutely adequate psychological support for our teams and our colleagues. So being able to recognise colleagues' stress, being able to recognise when we're not feeling resilient is also extremely important. And we'll be investing with our line managers and with our leaders and supervisors to get them to be in a better position as well to recognise within their teams when people are in distress so that we can help in a much more proactive way. And finally, one of the other things that we learned around our inclusion was about our disabled colleagues. So our disabled colleagues, many of them were asked to stay away, were asked to shield. So we've started to really think about how we can express that experience for them, but also about how, as they come back into the workplace, we can look after them, but also create toolkits for our disabled colleagues to be able to really simply explain to line managers what it's like to be disabled. We call that the About Me toolkit. So we've really tried to think carefully about what we need to do differently, knowing that our health and wellbeing service in the Hub is absolutely phenomenal, but we will need to develop it going forward. So I'm going to hand now back to the chair, who's going to introduce the patient.
Thank you very much, Emma. I'm delighted now to be able to introduce you to Rob Thomas. I'm not delighted that it's appropriate for him to be here today, and the reason of that, of course, is that he, several months ago, succumbed to COVID-19. I've known Rob for nearly 20 years now, and I've known him to be a thoroughly honest individual and one who pays great attention to customer care. And it's that which I think is so important for us to listen to someone who has been at the receiving end of all of the treatment and care that we've attempted to give. So, Robert, do thank you very much for joining us today and look forward to hearing your story.
Okay, thank you, Peter. Spending an hour or so in this room, I actually feel quite humbled listening to the other side of the guys that actually looked after me when I was admitted with COVID in late March, which, listening to the speakers just now, was kind of like at the peak and in the early stages. And just really to relay my experience of from a patient perspective, if you like. In ICU, I fortunately managed to stay off of the ventilator. I had the full CPAP mask on, and it was very, very, very difficult and frightening times. I was admitted into ICU sort of early hours of the morning. I went in. My wife had a phone call from the doctors telling her that I would have a 50% chance of surviving. And they rang her every day without fail to keep her up to date with my progress. The second day I was in ICU, I felt very low, and I didn't think I was actually going to make it. I felt that I just wasn't going to do it. And that's when I say a little nurse came along, bless her, but she had a New Zealand accent. I don't know her name, but I owe her a lot because she came over and she said to me, bearing in mind I was feeling that close to giving up really, and she came over and she said, "Oh, just to let you know that we've just rung Viv and the kids and we've told her that you're holding your own, and that we're going to do this." And she clenched her fist and she just punched me twice on the arm and she said, "And we're going to do this, we're going to come through this and we're going to do it." And it was that kind of attitude that when you're lying there on your own, just looking at a clock at the end of your bed, and you've got people like that sort of rooting for you and looking after you, kind of just gives you the boost. And there were so many times, I was 14, 15 days in ICU, and I was just sat there watching what was happening. And you see the teams have their meetings, and a nurse that hadn't actually looked after me before came over with a fruit shoot drink. And she said, "Oh, I've got you a fruit shoot drink, Rob." She said, "I've got you the banana one because we know that that's what you like." And even down to something like that, that meant a lot to me because my mouth was like sandpaper and bricks. And that was actually really important to me. And that's the level of, I would call it seamless care that I received while I was in ICU. That yes, I had the drips, the antibiotics, and it was kind of like nobody really knew that much about the virus and medically what could be done. But it's the people care, I think, that helped me get through it. I came out of ICU and I went into a recovery ward, and the doctor came along and he looked at me and he said, he said, "I've got to tell you, Rob," he said, "I've been sort of watching your progress in ICU. He said, "I've got to tell you, I think if you went on the ventilator, I don't think you would have made it." And it was down to the breathing exercises that you got, the breathing routine that you got into. And he said, "I'm going to call you King of the Breathers." And that kind of stuck with me. My family bought me a T-shirt with King of the Breathers on when I came out, bless them. It's just sort of things like personal things like that that kept me going. And they then nurses came along to me and said, "Oh, Rob, we're going to move you now and we're going to put you into the tower block." And I can remember saying to the nurses at the time, I said, "No, please, not the tower block, no. I don't, not the tower block." And she said, "No, you're going on ward 2B." And they put me on ward 2B, and unbelievable. The care that I received on that ward was just above and beyond. They had a dietitian nurse that came along to see me. And bearing in mind I hadn't eaten properly for like 15, 16 days, and she basically said, right then, Rob, we've got to get some crap inside you. You're either going to start eating or you're going to have a drip. So I said, well, we'll start eating then. And she took an order from me and for a cooked breakfast, and she went down to Foster's and she came back with a tray, a coffee in a china mug, proper knife and fork, brown sauce. And she put that on my bed and she said, there you go then, Rob. She said, that's your breakfast. She said, you're going to have that every morning, and I will get it for you. And every morning she came along and she got me the same cooked breakfast downstairs to Foster's on a tray, none of the hospital food. It was amazing. And again, it's the personal care like that was just. When I came out, I ended up on TV as a way of saying thank you to the staff, but it's just, it never seems enough, really. And then listening to the care and compassion that the guys have got in this room today it is just unbelievable, and it is amazing. And I owe them my life, really. And hopefully, I'm a very lucky survivor. I'm doing very well. I've had excellent follow-up care and support, and it's been amazing. And I don't think thank you would ever be enough for what they did for me. And when I came out of hospital and we clapped every Thursday night for the NHS, it was a whole new level for me. It was a totally different meaning. And they're an amazing bunch of people. And hopefully everybody will help avert a second wave being as bad as the first, because they don't deserve to go through that again. But thank you very much. Yeah, thank you.
Rob, thank you very much for that. Terrific to hear your story. What we'll do now, ladies and gentlemen, is we'll have a break until 25 past 5. Hopefully gives everybody a chance to grab a cup of tea, put the kettle on if you're able to do that, if you're in that situation. And then we come back, we'll have a financial review of the accounts with Karen Johnson. So back at 25 past 5. Thank you very much.
Hello, wow, how do I follow that? That was just so inspirational, those three speakers. This is why I work for the NHS. So, good evening, my name's Karen Johnson. This is my first annual members meeting here at the Trust as the Director of Finance. So I joined the Trust in January of this year, so I was fortunate enough to have a good quarter of experience in terms of the expenditure and income that was coming through to the Trust. I was also played quite a key role in developing the budgets for the coming year, but clearly that's been superseded by the global pandemic. So today I will be giving you a very high-level summary of the financial challenges and achievements of the Trust during 2019-20. Okay, so as with any organisation, we set a financial plan, and our plan was to deliver a deficit, actually, of 1.5 million. That means that our expenditure was going to exceed our income by 1.5 million. And you can see on the slide there that actually we ended the year with a very small surplus, which is a fantastic achievement. I've been in the NHS now for coming up to 11 years. And I've always been in trusts that have been in significant financial difficulty. So to have end the year not only overachieving the budget, but actually delivering a break-even position was just amazing. What you'll see, though, in those two figures is actually that when we look at our expenditure, our planned expenditure, and our actual expenditure, and the same with our planned income and our actual income, the differences are quite big. And the main reasons for that was each year, every NHS organisation has to deliver a level of efficiencies. And they become more and more difficult to achieve the longer the years that you have to make those efficiencies. So part of the reason why our expenditure was greater was because we had a gap on our efficiencies. The reason why our income was so much higher was actually we delivered more activity, which is a good thing. So therefore, we got more money from our commissioners. But predominantly, what happened was we ended the year with a very small surplus. And the reason why we ended the year as a small surplus is because actually we did achieve our planned deficit, and because of that, we were able to receive some incentive money from the government to the tune of 1.5 million. So overall, this position is supported, and it's important for you to note that most NHS organisations are struggling financially, and that was pre-pandemic. And as a result of that, we got national support to the tune of £21.3 million. And that support is an allocation that recognises the financial challenges across the NHS. And before COVID-19, there was a 3-year plan to try and make sure that organisations would become more financially stable, so that national pot of allocation would start to reduce year on year. The final bullet point here is around our SIP delivery. As I mentioned before, we had to plan to achieve £22.4 million worth of cost improvement. So that is a reduction in our expenditure. We did only deliver just shy of 15 million. And of that 15 million, only 64% of it was an ongoing saving. So the more ongoing savings that you can make, the better it is for the coming year. So what did we spend our money on, and where did our income come from? So you can see on this slide that we spent just shy of 400 million on pay. So our workforce is by far our greatest expenditure criteria. We also spent 213 million on non-pay, but about 30 million of that is not expenditure that relates directly to patient care. And what I mean by that is it means expenditure on depreciation and capital charges and interest. But we do spend an awful lot on clinical supplies and drugs, and actually our premises and our buildings. So last year we also generated just shy of 600 million on income. Predominantly, over 500, just shy of 500 million is on patient care, and that comes from our commissioners. And you can see their breakdown in terms of where that income comes from. We also get some income from non-patient activity, research and development, education, private patient income, overseas income, and it all contributes to our overall financial position. So we talk about revenue quite a lot, but actually capital is just as important. We've got 2 sites here on the Gloucester and Gloucester hospitals, and let's be clear, they're not modern buildings, and that means that they take quite a lot of maintenance and upkeep. And this just breaks down where we spent our capital allocation for last year, and you can see in total we spent £34 million. Now, it's really key that we spend all of our capital allocation in the 1 year. Because unlike the private sector, where if you've got a capital allocation, you'd spend it over the life of the project, which tends to be greater than a year, especially if you're building a new hospital. The NHS doesn't quite work like that. So capital is given to us on an annual basis. So it's really important that we spend the money that we're allocated in that year. And if we don't, we pay it back. And we lose it, so we cannot carry it forward. And Gloucester, when I first arrived, was slightly behind the capital plan, so it was really important that we moved at pace to ensure that our capital programme was spent fully by the end of the year. And I'm pleased to announce that we had a slight over allocation of our capital spend, so we didn't have to pay any of it back. So looking ahead, so we've had some great stories today, haven't we, around the impacts of COVID. And actually that impact absolutely transfers onto the financial position of the Trust. In the first couple of months of the financial year, we were spending thousands of pounds on PPE, testing, remote working. Most of our non-clinical staff ended up working from home within days of being told that we had to work from home. It was amazing how the organisation responded to COVID. I'm very proud to be part of it. Deborah's already mentioned about actually the financial methodology that was used for the first 6 months of the year. The government was very, the message from the government was very clear. They did not want cash, they did not want money to be a barrier. And it absolutely wasn't. And it allowed us to work together as a system, as an organisation. But unfortunately, that financial regime is has come to an end. So it finished at the end of September. And we're now trying desperately to understand what the next 6 months looks like. And what I will say is there's much more rigour, there's much more grip and control, and there's a finite pot of money that all systems have been given, and we're just working through what that looks like. So moving on to 21-22, very, very uncertain year. But one thing we will do is embrace it with the professionalism, commitment and dedication. Thank you. That concludes my presentation. I'll hand back over to the Chair.
Thank you very much, Karen. I have 2 roles, actually, because Foundation Trust chairs are not only chair of the board of the Trust, but they also are chair of the Council of Governors. And it's that role in particular which I enjoy, because it enables me to meet some really wonderful people and develop some one-to-one relationships with them. But tonight I'm not going to go into too much detail about the individuals on the council. My job is pretty much to be the returning officer, if you like, as a result of the recent elections that we've had. So I'm just going to go through all of the constituents and highlight what has changed in each area. So first of all, if I look in Cheltenham, no change there. We continue to be extremely well served by Alan and Tim, and I'll say a few words about Alan when I hand over to him in a little while. In the Cotswold district, I would like to congratulate Kate Atkinson on her election, and also Anne Davies on her re-election. And I have to say, Anne, thank you very much for the message that you've just sent, thanking everybody in this room who's been presenting. It's a really wonderful message of thanks, so I acknowledge that, Anne. In the Forest of Dean, we have one vacancy still to be confirmed, and that person eventually will join Hilary Bowen. In Gloucester, we have Liz Berrigan, who's been re-elected. Congratulations to Liz, and she joins Graham Coughlin. In the out-of-county constituency, I'd like to congratulate Nicholas Price for joining the Council of Governors. And in Stroud, I'd like to congratulate Debbie Cleaveley, who's been elected, and she joins Pat Eagle. And no change in Tewkesbury, with Jeff Cave and Kedge Martin continuing to serve as governors for that public constituency. In terms of staff, quite a lot of change. Again, I'd like to congratulate Fiona Marfleet, who becomes the new Allied Healthcare Professional Representative, and Russell Peake, who takes over the role as Medical and Dental Staff Representative. Sarah Mather has been re-elected as Nursing and Midwifery. Julia remains in post. There was no election there. And would like to congratulate Caroline Claydon for her election as other and non-clinical staff. So just a little bit more detail behind the names that you see there for the staff governor constituents. And then no change in the stakeholder appointed governors, with Matt, Colin, Maggie and Pat continuing to serve their respective organisations, the Gloucestershire County Council, the CCG, Health Watch and Gloucestershire Age UK. So as I said, I'd love to spend all evening talking about each of those individuals, or the ones that I know, but I won't do that because I will steal the thunder from Alan Thomas, who I'm going to introduce in a second to speak. It's always a pleasure to do that with Alan. I say that because I always go before Alan, and it means that I can just perhaps preempt a little bit of what he's going to say, although if anybody knows Alan, that doesn't really work either. So, Alan, I have no idea what you're going to say, but I look forward to hearing from you anyway. So, welcome, Alan.
Thanks very much, Peter. Firstly, I'd just like to say I don't normally wear a tie. It is a rare occasion, but just on the off chance that my mother is watching, I occasionally do look relatively smart. So this is the 7th time I've appeared at an annual members meeting in one form or another. It's always a privilege, I think, to hear what the Trust has done over the years. And I've seen a lot of change in that time. COVID, of course, has been a huge change to the way the Trust has had to manage its business. Firstly, I'd like to congratulate all my new colleagues that I haven't met yet on the new Council of Governors, but I'd like to say a particular word of thanks to those who have left us. From the staff side, to Tom Llewellyn, to Nigel Johnson, and to Charlotte Glasspool, are all strong staff governors over the last 2 to 3 years. From the public side, I'd like to thank Jeremy Marchant from Stroud, who's been particularly keen on the engagement side of the governor's role, and I'd like to thank him particularly for that. I'd also like to thank Marguerite Harris, who was the out-of-county governor, for her service during the last 3 years. I'd also like to welcome Patla Rolland as an appointed governor. I know she's been a governor for a while. I've never met her. COVID has meant that we've had to do all our work virtually since March. This is only the 4th time I've been privileged to come back into the Trust since March the 11th. I wasn't faced with so many cameras before. But it's been a different experience. So I'd just like to say what we have done and what we are looking forward to. Very simple slide. Looking back, Well, COVID clearly has been a big thing over the last period. And you've heard a lot from the Trust about this. I don't really want to go over it from the health perspective, but I think two aspects of what's gone on in the previous 6 months from the governor's perspective has been particularly staggering, really, in the way the Trust has done its business. It's been led remarkably well by the Chief Exec and the Chair and all the staff, and we, of course, give a great big thanks to everybody. I know of many trusts, many governor colleagues in other parts of the country who have had no meetings. This Trust has managed to continue with all its governance processes throughout this pandemic. We have had board meetings, council of governors meetings, extra special governors meetings to deal with all sorts of things. All its committees have carried on, and we've really been allowed to do our job even though it's been at the end of a computer. And I really want to thank the leadership of the Trust for that, because I do know that many trusts have not bothered with that. And the second aspect, I think, which hasn't been played as much as it could have done, is the IT and digital. Well, just the whole way that IT has changed in the 6 months. Those of us who know me will know we've been very critical as governors of the digital space in this Trust in the past. No longer. It's been quite remarkable what's managed to achieve for the patient's perspective in the last 6 months. And I want to thank particularly Mark Hutchinson and his team for what they've done there. So that's the sort of thanks, and that's the sort of looking back. What about the governors in the last year? Well, apart from doing our business of checking on what the Trust is doing, I think we have improved our communications. It's proven more difficult than we anticipated because of COVID. We've had to do it virtually, but we have begun the process of direct communication with you, the members. There have been direct emails, and believe it or not, I've had 1 or 2 direct emails back to me. So that's improvement, because it just didn't used to happen. I'd encourage you in the future, if you can, and you want to ask a question of us, the governors, use the Contact the Governor facility. It is on the website. Jeremy Marchant, who I mentioned, along with Jeff Cave, ran a task and finish group to improve our engagement with members over the past year. And they were doing really well until we had to really stop what we were doing on a face-to-face basis. We've every possibility that we will do things better again in the future. And although I say this every year, I am confident that if the pandemic ends, we will do a lot better. So in the future, we can do better to communicate with you. I don't think we do it well enough. But what are we going to concentrate on over the next 4 years in our communications? Firstly, the Fit for the Future and the temporary service change. Clearly, these are areas of great interest to you all. They have great interest to us as governors, and we have asked many challenging questions over the past period, and will continue to do so. Where we feel that change benefits the whole of Gloucestershire and not simply parts of it, we will support that, because as governors and as a council of governors, collectively that is our role, to represent the interests of the public. Safe, efficient and caring care, that's what the NHS is about, and that's what the interests of the public are, and that is what we try to achieve in our challenge of the Trust. So where we feel we can support, we will. Where we feel the Trust needs to think again, we will challenge the Trust to think again, and they have thought again over the last period. Temporary service change also, we are cognizant of the statements made about the ending of that period, and we will keep our eyes on it. Another thing that we will do over the next period is to agitate, if that's the right word, for the continuing reappearance of the patient care that's had to be postponed. We'll be looking at the way patients are communicated with, over their pathways to remove anxiety, and we will continue to ask questions about how well that is going on. We will also continue to agitate for those in the community who are less well represented, both in the Trust but also in the community as a whole. We've heard about the BAME community, which has been perhaps not well best treated. We also have made many comments about mental health within the community, and we'd also like to encourage the younger people of our community to get more involved. And I'd like to thank particularly Anne Davis for her work in the youngster, well, the whole area of younger people. And I do know that some of our newer governors have an interest in mental health, as I do. And finally, in terms of where we will concentrate our efforts, we hear a lot about the way the system has, and by the system I mean all the institutions of the NHS within Gloucestershire. We've heard a lot about the way the system is coming together to act collectively to improve our lives. Well, that's fine, and we support that, but we would like to see, as governors, a bit more accountability from that system to the people of Gloucestershire. And so, as governors, which we feel in this Trust, we feel it's open and transparent, and we always get answered any questions we give to the Trust. We'd like to think the same will happen over the next 12 months to the way the system develops. I'd like to end by just, Deborah, I think, mentioned the storm and the boats analogy, which is, I think, a great analogy. I'd like to use the phrase from the patient perspective, the public perspective, and hope that everything the Trust does in the next 12 months, which it has done in the previous 12 months, nothing about us without us. And I think that's how I'd like the Trust to think of the patient. Thank you.
Great, thank you very much indeed, Alan. I think you're right in that we can do more to enable governors to work more closely with the members, but notwithstanding that, I would like to congratulate you and the governors in the way that you do represent members, notwithstanding that, in a very suitable combination of collaboration and challenge to ensure that we do keep our eyes focused on the ball. And personally, I'd also like to thank you for your wise counsel, which I do regularly appreciate. And I won't mention Cardiff City. Right, now I'm going to... So thank you very much, everybody, for sending in questions. We've got some great questions come in. I'm going to invite Deborah Lee to come and join me up here. And we're going to do a bit of a double act in terms of fielding and answering some of the questions. So I'm just going to sit down here. You'll notice we are suitably socially distanced.
And of course, we're not going to do a double act because I'm going to involve my executive team in helping me answer some of those questions. So we'll be, what do we call a group of...
It's a multidisciplinary team.
That's the one.
Can I just pick up the first one then? If COVID increases as it did before, will you have to stop doing other things like you did last time?
Great question, and certainly a concern that I hear expressed widely. The key rationale underpinning the temporary changes that we've put in place is to ensure that should we find ourselves responding to a pandemic of a similar scale, that we absolutely don't need to pause and set aside the number of services that we did the first time. You might have heard us talk about our two hospitals representing an opportunity rather than a problem or a challenge, and that opportunity will allow us to continue to do operating, both inpatients, day surgery, continuing to provide access to important diagnostics like CT and MRI imaging. So absolutely developed a plan for this next phase that won't require us to set aside the same volume of services. I think there will be an impact. It's important, I think, to be honest about that, but it won't be anything like the order we experienced the first time.
Good, thanks. And here's a linked question, if you like, I think. Can you reassure us that patients who need to come into hospital for non-COVID treatment will be kept safe? And I guess I'd add to that, and how will you do that? How will we do that?
So it's absolutely important, isn't it, that we have the confidence of our patients. And there's a question later on about health inequalities and how do we ensure that we reach everybody in our community. And so for me, it's really important that our messaging is both clear but also targeted and nuanced so that everybody understands how to come into hospital, how to access care. I'm going to invite Steve, my chief nurse, to just talk to us about some of the measures that we have taken to ensure that when patients come into our hospitals, they can be assured that they're safe. And perhaps asking to start by just talking about where we are at the moment, because I'm really proud and impressed with our approach to infection control and the extent to which our hospitals are a safe place to visit for those that don't have COVID.
Thank you, Deborah. We have been working extensively over the last few months to ensure that our hospitals are safe. We have a wonderful infection control team in our organisation. In fact, our infection control team during COVID increased to 8,500 staff, so we all played our part to ensure that our services were entirely safe. We've implemented a whole range of things to ensure that we are COVID secure. And when you come into our hospitals, either as an outpatient or for an inpatient services, you will see a whole range of things. So our staff are wearing masks, there's hand hygiene. We've implemented some very special screens in between our beds. And one of the important things that we can demonstrate really good outcomes for our patients in Gloucestershire is the transmission rate in hospital has significantly reduced. In fact, during August, there were very few, so less than a handful, whereas other organisations have seen had a difficult time with the number of inpatients that have ended up with COVID. So we've been working hard. We continue to work hard. We have social distancing guardians across the organisation. We have PPE safety officers, all supporting our colleagues to ensure that we provide a safe environment for our patients, but also for our colleagues. So lots and lots of work going on.
Thank you, Steve. What I'd add to that, Peter, also is that we recognise that for some people the risk is greater. So those people who are perhaps shielded the first time around, who are particularly anxious about coming back into hospital care, is to contact us, to speak with us, and we can, if needs be, make special arrangements for those individuals, because the most important thing to us is that COVID doesn't become a barrier to people receiving the care that they need, as it was for some in the first wave.
Thank you. Many of these questions are anonymous, but some aren't, and I will read this one out in full. I asked the same questions I did last year at the annual meeting of this trust, this being, what measures are we going to use to address health inequalities? If we have no appropriate measures, how will we be assured that we are tackling health inequalities and not worsening it? And that's from Bren.
So there are two distinct things there, aren't they? How do we address health inequalities and ideally prevent them and certainly stop them from worsening, but also how will we know we're succeeding? So if I just take the first one at a high level, and then perhaps I could ask Mark Pietroni, our medical director, and really helpfully for us, an expert in public health, to talk a little bit more about it. But for me, the most important thing is that we recognise that health inequalities exist, that we're not all starting from the same place, that for some people it is harder to access care, both in terms of understanding how to do that, but also making that possible. So, for example, there are communities that are more disadvantaged or predisposed to some disease, illness than others, making sure, therefore, that our offer to those in terms of the sorts of services we provide will make it easier for them to access care. A good example of that, for example, if we think about a travelling community, we've got some really great services delivered by colleagues outside of hospital that reaches into those communities to make sure that they can access, for example, immunisations for their children, because we know that they're less likely to perhaps be children that are in contact with health visiting services, for example. So it's really quite a targeted and nuanced approach. In terms of how do we measure that? Well, increasingly we are getting more sophisticated about ensuring we understand the demographic of our population. What do I mean by that? Well, when patients come into hospital, and this isn't an easy conversation to have, is it we'd like to understand more about our patients. So it's their age. People are usually quite happy to share their age, but conversation about ethnicity or other factors is less straightforward. But unless we know that, it's quite hard then to look at where we're having our impact. So we'd like to understand are more patients from an Asian background experiencing heart attack than those from my own white British background. Without that information, it's hard to measure progress and success, but increasingly we are capturing that sort of information. Mark, did you want to add anything to that? Mark spent a career before here as a public health consultant and is probably therefore the expert in this field. No pressure, Mark.
Well, how long have you got? I could talk about health inequalities for a very long time because it's very close to my heart and what I've done for most of my career. Health inequalities, if you wish to reduce health inequalities in a community, you actually have to turn the question the other way around. You have to start promoting good health. And it's about health promoting activity rather than seeking to treat ill health. And of course, that's a particular issue for us in the hospital because actually our role is to treat ill health. There's a phrase that I quite like, which is that health is made at home, hospitals are for repairs. However, in the context of the hospital, I think the most important thing is that we walk in the shoes of the people who we are seeking to help. Because unless we do that, we won't understand, in particular, the barriers to access. Actually, one of the most wonderful things about the National Health Service is that it significantly reduces barriers to access to care because care remains free at the point of treatment. But that's not to say that there aren't other barriers, particularly social barriers, that prevent people from accessing care. Simple things like if you write a letter to somebody who can't read to tell them about an appointment, then don't be surprised if they don't turn up. So we have to walk in the shoes of the people that we're trying to help, and we have to work together with our colleagues across other health and care institutions in the local authority and primary care, etc., to understand how we can reduce, in particular, those barriers to access. And then we have to hold ourselves accountable for that by making sure we assess in relatively straightforward ways that we don't actually stop people getting the care they need by the way we design services or the way we operate. I will stop there because, as I said, I could go on for hours and hours about this, but it's really important and it's very close to my heart.
Thank you very much, Mark. Vernon asks, thanks for the opportunity to ask a question. Please remind the meeting what additional policies, processes and protections are in place for BAME folk. Vernon, I don't know whether you mean patients or staff, but we could take both actually and comment on those. I think would be very valuable.
And Emma come up. Emma Woods, Director of People. If you've been with us for the whole evening, you've heard Emma talk before, and she did touch on this. I think Emma probably talked perhaps broadly about risk assessment, because I think it's not just colleagues that come from our BAME communities that we know are at greater risk.
Yeah, so to start with, we obviously write all our policies and processes so that they are fair and equal for all of our protected characteristics, which includes, one of which is our BAME staff members. So from a policy point of view, they are all inclusive. We do have some practices, though, that we have put in place to help with our BAME colleagues in terms of things like career progression, and also to ensure that we understand better their specific needs in terms of progression within the organisation. So an example for that would be we have positive action within our recruitment policy. We can take positive action where that's appropriate. We also have our diversity network, and we have a BAME subgroup, and that BAME subgroup helps inform the Trust in terms of practice, what's the best practice given the ethnic minority and communities that we both serve and our staff members.
Thank you very much, Emma. Let's go to another anonymous question. What are the trusts doing to improve the situation in A&E in Gloucester? with regular large numbers of ambulances parked outside, unable to offload patients, and Cheltenham A&E downgraded and empty beds around the hospital. And linked to that question is a question about, can you assure the public that Cheltenham's A&E will not be permanently closed? We've already seen that Gloucester can't cope now, and we're not in winter, so a couple of questions about ED, Gloucester and Cheltenham.
And Mark and I will do another double act, because this is something that we both have spoken about at great length. But I am very happy, as you will know, Peter, I've done many times in many different forums, in print, on video, on radio, really happy to confirm that the temporary changes that are affecting Cheltenham's A&E will not become permanent. I think I couldn't be clearer, and I don't think this has changed throughout the pandemic. I was really clear when we took what was a very bold decision, wasn't it, to make the change to Cheltenham, that it's a service that's really valued by local people and something that's very, very dear to that community. But what we were looking out for during the pandemic, and this is the role of an organisation that serves the whole of Gloucestershire, isn't it, not just one locality, is designing a model of service for the winter that would give us the best chance of ensuring that the whole of Gloucestershire was able to continue to access care that was safe. And one of the key objectives that we had, and this was a national ask, it wasn't just a local, was that we controlled admission into our hospitals in a way that meant the risk of transmitting the virus to other patients and to our staff was absolutely minimised. And we couldn't do that twice in the county. As you would appreciate, we have patients who we know have COVID because they've perhaps had a test and are coming to hospital to be cared for. Those whose symptoms are suspicious and we suspect may have COVID, but because they may not, we want to be very careful with that group. And those who, for example, may be coming in for routine surgery, have had a test and we know that they haven't got COVID and we don't want to expose them to any risk. So that's already quite a complex picture for coming into hospital. And we simply didn't have the workforce and the physical space, and in particular the laboratory testing capacity to do that both in Cheltenham and in Gloucestershire Royal. And our view was that we could do it most safely and most appropriately at Gloucestershire Royal. So I think it's really important to understand why we did it. We certainly didn't do it to restrict access to care for people in Cheltenham. We did it to give us the best chance of keeping as many services going as possible. You've heard us talk about that. People have talked about Cheltenham being a green hospital where patients can come with confidence for cancer care when they're at their most vulnerable, for diagnostic care when they may be shielding, for example, previously. So a number of objectives we were trying to achieve, and I entirely understand why, if you're somebody that wants to access local care, that might seem, I've heard the language, like a downgrading, but actually in this context there's broader objectives of making sure we keep everybody safe during the pandemic whilst treating COVID and non-COVID patients equally, fairly, appropriately, safely to the same high standards. I remain of the very strong view that it was the right approach and one that will serve us very well, during winter. I forecast there will be organisations around us that will stop operating, and we won't do that in Cheltenham. Mark, is there anything you want to add? I think particularly if I could ask you to just touch on this notion of how this is impacting on the department in Gloucestershire Royal, on patients, on staff, because it is a unit under pressure. We don't shy away from that acknowledgement, that fact, but again, in the context of the bigger picture.
Thank you. Yes, Deborah has explained that COVID permitting, sometime in the future, the A&E department in Cheltenham will go back to the way it was before COVID. And she's also explained the reasons why we made the changes that we did, which is about ensuring that we can provide as much care as possible to all of the patients that we serve, not just those that come in through our emergency departments throughout the next COVID pandemic. And as the numbers rise at the moment, we're really very much in the foothills of the next battle, if you like, and when these changes will serve us well. Actually, it's important to say that the department in Cheltenham remains open. It's quite possibly the best staffed minor injuries and illness unit in the country, with a very senior level of medical and nursing and advanced nurse practitioner staff. So the service that people get when they go to Cheltenham is actually absolutely first class. And I would encourage people to continue to go if it's appropriate for them to go there. In terms of what we're doing in Gloucester, I think it's fair to say that the whole country has been surprised by how quickly A&E departments returned to pre-COVID levels of activity, and that's taken us by surprise, certainly. However, we do have a number of plans in place, some of which are already happening and some of which are due to happen. So, for example, we've received monies from NHS England to increase the size of our emergency department and put modular builds in, which will help with the space issues that we have. We've already taken over the fracture clinic, which is right next to the A&E department, and we've already moved some services out of the A&E department. So, for example, the paediatric A&E has moved to the paediatric department. And so we've already increased the footprint by about 85%. But looking at ways in which we can ensure that patients who don't need to come to A&E but do need to be seen go direct to the specialty that needs to see them, so that patients with a surgical problem will go to the surgeons and patients with a medical problem will go to the medics, and those patients won't come through the emergency department at all. Again, helping with the crowding, particularly where the ambulances offload, but also with the workload of the department, so that the staff in the emergency department can focus on the patients that they're best able to look after. We're also looking very heavily at our triage services to make sure that those patients that do come into the emergency department can be moved as quickly as possible to the right part of the trust in order to get their treatment, so that the time delay between coming into the emergency department and getting, for example, to one of our ambulatory units or one of our assessment units is reduced. That's obviously much better for the patient, and it also helps again with crowding in the emergency department. And we do know that when our emergency department functions well, it's a fantastic department. There's no doubt that it's been a struggle on some days, and there's no doubt that the staff have been under pressure, but we've gone around this one again and again, and we are all in agreement that this is the right thing to do to provide as much care as possible for all of the people of Gloucestershire across all of the services that we provide going into the winter in the context of another COVID surge. We're doing all that we can, and we'll continue to provide the best care that we can in our emergency departments, but also across the whole range of services that we provide in the Trust.
Thanks, Mark. That's really helpful. And I think one thing I'd just kind of crystallise, because this is a question that goes around in my head, and people have asked me it as well, and I've heard others say that if you just reverse these changes, then everything would be okay and Gloucestershire would be in a better position. So I think it is really important to just end with that bigger picture piece around a whole raft of benefits. So inevitably and clearly, if you're a patient who previously went into Cheltenham with a shorter wait and is now coming to Gloucester and experiencing a longer wait, you will feel as though your care has suffered. But if you're a patient who can have their hip operation because we're continuing to operate, or a cancer patient who can continue with their chemotherapy, or somebody who's not at risk of catching infection from the person in the bed next to them because of all of these changes that we've made, then most of the people that I've spoken to, when we've been able to have that conversation about, well, what's the forfeit, what's the opportunity cost of this thing that I'm suffering, I'm experiencing, when you can explain that and take the time to explain that, I've just been so heartened by how understanding and accepting people are of, again, their little contribution to this bigger benefit for the whole county. And I can't thank patients and families enough for being willing to listen to that and to accept that they're playing a small part in ensuring that the whole county can continue to receive care, whether or not they've got COVID or non-COVID. So important.
And sometimes they don't have the loudest or most organised voices either, do they?
Absolutely not. Yeah, absolutely not.
So another service one I'm going to pick out, phlebotomy. Phlebotomy services at Sirencester Hospital are severely restricted and will discontinue at the end of October. The surgeries will not offer blood tests to hospital patients, which means those of us having chemotherapy at GRH have a round trip of 36 miles. when will the service be restored? I think that's Elaine.
Well, thank you, Elaine, and I shouldn't even smile about this, should I? Because this has been a really, for many people, this has been really distressing. It's provoked a lot of anxiety and concern. If you're a patient, for example, being cared for in our oncology service, undergoing chemotherapy, the last thing you should be experiencing right now is worry and concern about whether you can have a blood test that your oncologist says you must have and that you must have, you know, in a particular time window. So I'm really sorry that people have been impacted through the changes that are underway in services. So I won't, Peter, go back on the history of why we are where we are, other than to acknowledge that I don't think as partners in Gloucestershire Health System we've handled this as well as we might have done, and that's put patients in a really inconvenient place. What is important to note, however, is that we have a really clear way forward. This is a service that my organisation, that Gloucestershire Hospitals, provided in the past, but we signalled that we didn't want to continue doing that. That's not an unusual situation. Our focus is on delivering within hospital care, not out of hospital care, and we were very grateful that our partners in Gloucestershire Health and Care Foundation Trust agreed to take that service on. But what's been described here is a transition that hasn't worked as well as it should. But what I can reassure you is that we have a way forward. By the end of this month, we'll be back to running that phlebotomy service in Sirencester 3 days a week, not just the one that we have now, and by the end of November, 5 days a week. So service will be resumed. It will be the same great standards and quality that it was. And as I said, just reiterate my apologies that for that short period of time, the service wasn't as we'd have liked it to be. And I don't think we communicated that as well as we could either, Peter. It speaks for itself, doesn't it, that as we deliver more care virtually, you know, you're on the phone, you're on a video, and the doctor says you need your blood taking. It makes little sense to drive from Sirencester to Gloucester or Cheltenham for that blood test. So we absolutely understand the importance of that community-based provision. And similarly, if you are vulnerable and you have particularly if you're at greater risk of COVID, why for the next months would we ask people to come into hospitals where we know the rates will be higher than out in the community? So for all those reasons, it's right that we have got plans to restore this, and we will do by the end of this month.
Thank you. We'll stay clearly patient-focused for a moment. Another question. I'm pleased to see you acknowledge that the quality of hospital discharge isn't as good as it should be. What are you doing to improve that?
Yeah, thank you. And this was in my slides, wasn't it? This is one of the what we should have done better. Steve, do you want to come up again and talk about it? Because one of the things that I do, and I've probably said this in previous years, but a great way of walking in the shoes of many of our patients and families, as Mark alluded to, for me is to sign the complaints letters. So unless I'm on annual leave, I sign every letter that leaves the organisation, and I read it before it goes. It gives me a great insight into how we're delivering care. And one of the themes that I'd love to see diminishing and disappearing is about discharge, which isn't always as good as it could be. You know, what are those themes? Well, they may be that somebody's been discharged much later in the evening than is ever ideal. It may be that there was some confusion perhaps around the medication. Would it be at home? Do they collect it from the pharmacy? So what might seem like small things but can make a huge difference to the quality of that discharge. So Steve has had this as a focus, well, particularly I think, Steve, a strong focus in the last year, but I think on the back of the most recent inpatient experience survey that shows that we're still not getting this as right as we need to. It's a really heightened focus. So, lead off, Steve.
Thank you, Deborah. And you're absolutely right that discharge is really important for our patients and their families. And we recognise that discharge is often the last experience our families and our patients experience with us. So it is really, really important to get that right. Generally, on average, we discharge between 80 and 90 patients a day across our hospitals. So it's a high volume, but actually it's really important that we broadly get it right. Discharge is often something that we have to share across a range of organisations, a range of multidisciplinary teams, particularly those patients which have more complex needs. So it can sometimes be a little bit more complicated. But we've been doing some great work over the last 12 months, and we recognise there's still more for us to do, but some really great examples of where multidisciplinary teams like nurses, occupational therapists, physiotherapists and our doctor teams have been working with adult social care and other organisations to really improve discharge. So just a couple of examples. We now have a discharge hub. We have a discharge bureau where teams meet twice a day to talk through some of the complex issues that some of our patients experience in order to be able to expedite the safe discharge either to home or to our onward care facilities. A great thing in terms of the last 12 months, because we've implemented our electronic patient record, we're getting rid of some of the paperwork which actually delayed things and delayed time. So much of our work is now done digitally, which means we can send things to other organisations more digitally. We have things like the home trials service where our therapists are trialling patients at home, so they're supporting them at home. The Home First pathway is really, really important, where patients are not assessed in hospital, because we know that when complex, particularly frail, older patients are assessed in hospital, it's not their normal environment. And I had a great example just yesterday where a colleague was sharing that his grandmother was in hospital and couldn't make a cup of tea, but got home, was able to do it and was functioning brilliantly. So it is really important that we assess patients at home, and we've been working with adult social care colleagues to ensure that we get to that point. We've increased the number of assessment beds, and we've also been doing some work across the Gloucestershire system around how we integrate our frailty service. And the other thing, I'm really delighted that we're working with Dementia UK, and this week our first Admiral nurse started, and Asma, as our Admiral Dementia nurse, will be working with those patients who come in to hospital, are often very complex and have a number of different care needs, to safely discharge them. So lots of work going on, lots of discussion with families, but also our patients about how we can make those improvements and get them even better, but recognise there's still some more work for us to do.
Thank you. Steve, you might want to stay there for the next question, but before that, I'm just going to highlight a comment from someone on discharge. Comment on discharge: yes, the procedures are bureaucratic and irritatingly slow, but far better than the John Ratcliffe, where I was referred to earlier this year. So I guess we take no pleasure from being better than colleagues in different parts of the world, but I think your answer was very thorough, so thank you for that. So the reason why I asked, this might be one for you, how can the Trust, this is a pre-submitted question, how can the Trust improve their assessment and care for those frail elderly who continually fall, as to what next steps to safe living are needed?
Thank you. A really great question and a really important one. And I think falls and pressure ulcers are the two things that are so important to me and my team. It's the area where we know that particularly frail older people have a risk of coming to harm. We've been really successful in the last year in terms of falls. So the number of patients who have received harm as a result of falling has reduced, and statistically so. But we know still too many patients are falling. So we have a fantastic team, and again, a multidisciplinary team of doctors, nurses and therapists and others who have been working hard over the last year to implement a range of things which are supporting our particularly frail older people. We know that deconditioning, so when older people come into hospital, they're not as active, so their muscles don't work in the same way. But actually, if we keep people in the bed and we don't exercise them, we don't get them moving, they can decondition. So we've been doing all sorts of things in terms of something called end pyjama paralysis. So we've encouraged our patients to get up, get dressed and get moving. And that really does help in terms of improving people's stay in hospital, but also ensuring they don't stay too long. A couple of other things that we've been doing, we've invested in our nursing team over the last 12 months. A couple of areas where we know there have been a number of patients that have fallen. We've invested in additional nursing and healthcare assistants. And being able to observe patients has been really important. And one of the interesting things that we noticed as part of the implementation of our electronic patient record is fewer patients were falling because our nurses and healthcare assistants were using the digital opportunities to be able to be in the bay and were therefore observing patients. The other thing we noticed, and it's been a bit of a shame during the COVID period because of visiting, is that when we increased our visiting probably about 18 months, 2 years ago, the number of patients falling reduced, and actually reduced quite significantly. And again, that was because relatives and visitors were available. During the COVID period, it's been a bit more tricky because we've had restricted visiting, so we've been supplementing that with our own staff. We've been doing other sorts of things. So again, back to our digital work, we now have all of our falls assessments online, and our teams have been working tirelessly in the last 3 or 4 months to ensure that they're completed. And we've had an exponential rise in the number of assessments that have been completed, which is great because we're identifying those frail older people who are likely to fall and then putting the appropriate interventions in place to ensure that they don't. Recognising there's still some more work for us to do, we've had some good success in the last 12 months, but it is a personal area of continued focus to ensure that we don't harm our patients. Thank you.
Thank you, Steve. As I said earlier this evening, we've had a few questions which are very detailed, to which we've already supplied some answers, and we'll continue to ensure that those who have asked the questions are satisfied with the answer, but they're too detailed to go into this evening. But probably time for just 2 or 3 more, I think. This one, I think, is really important. How are you making sure that everyone who is impacted by a change in their care knows what is happening to them? And we talked about this at board today, didn't we? And it's really important.
Yeah. And if I may, Peter, I'm going to link that to another question I can see that's come in, which is about a specific question about somebody whose child is waiting for an appointment in ENT, and for deafness, so for something that is of concern. So just to kind of look at those things together, as I've said, we have got considerable numbers of patients waiting. We were able to continue with around 30 to 40% of the elective operating we routinely do during the COVID period, so more than many. For cancer care, we managed to maintain around 45% of our usual levels of operating, but we do have a backlog of patients now to treat. We are in the process of sending out letters to 12,000 patients. So these are patients who are, if I can put it this way, on our books, patients who have been referred by their GP who may not yet have been seen at all. Or it may be somebody who's seen, was added to a waiting list and now is wondering when they'll get their cataract done or their hip replaced or whatever it is they're waiting for. So that letter just explains what we're doing. It describes our approach to prioritisation, because sadly that is what we need to do. And the reason we need to do that, of course, because some people, the detriment to some from waiting will be greater than for others. Let me use the sort of language of red, amber, green. A patient that would have been classified by us as a red patient is somebody that is typically on a cancer pathway, who's waiting for surgery, who, if they don't get their surgery in the most timely way, may have a poorer outcome as a result. So they would be prioritised for care sooner than somebody who may be waiting for a routine appointment. Doesn't mean they don't need their care, but when they access their care, the outcome will be the same for them. It may be a delayed outcome, but it will be the same for them. And those patients will not be seen in such a timely fashion. So we're not sending out 12,000 letters in one go, because many of those patients will want to ring, talk through their particular care, understand the timeline for their appointment. So we're sending them out in a phased way over the next few weeks. There are contact numbers patients can ring and find out about the specifics. So for this gentleman whose son's waiting for his ENT appointment can find out exactly how he's been classified in terms of category and when he can expect to be seen. Final comment, because I think it's really important that we're candid in this moment, is that the waiting times that we've strived so hard to achieve we've lost that. That's run away from us. Patients are going to be back to waiting potentially in excess of a year for their care, and I just want to stress how much that saddens me. But importantly, our colleagues, my colleagues, don't come to work for their patients, have to wait to get the care they need. And just to acknowledge how difficult that is for many of my clinical colleagues, because they come to work to deliver great care, and they've strived tirelessly since I arrived to get our waiting list down from really quite high levels to some of the best nationally and locally. So to be looking out now at waiting lists and having to address that again is emotionally a really big ask of them. But I couldn't be prouder of the fact that they are giving us of their time. We're doing clinics in the evening. They're prepared to work weekends. We're doing all that we can to deliver as much care as we can. But again, back to that earlier regard for their well-being and the time that they need to spend with their families, as well as the time that they give to us.
And we heard a bit about that earlier today, didn't we, from Kate?
Yeah, we did.
Probably one last question, I think, and very much on this theme. What is the Trust doing to assure the public that people working from board to ward at the Trust are not consistently working ridiculous hours? How is the public assured this is happening and will continue to happen from board to ward?
So I'm just going to summarise there, because we've produced a written answer to that question for the person that asked it, and I hope that's helpful. So a couple of headlines is, firstly, I hope that throughout the course of this evening we've conveyed how much it matters to us that we look after the health and well-being of our staff, and that nobody feels compelled to overwork. Kate talked about some of the challenges when she was in the peak of the pandemic, but I hope what you also heard was the 3 days on, the 3 days off. So recognising that resting colleagues is also really, really important. Thankfully, we've got some really valuable legislation that guides us. So you may have heard of things talked about the Working Time Directive that prohibits staff from working beyond a certain number of hours. That doesn't apply, though, to every staff group in the NHS, and so we also have systems that allow us to track how many hours people are working. If you're a manager that's like to roster their team every day for 20 days in a row, you can't actually do that. We've got a rostering system that prevents you from being able to do that. And we've also got things like policies around secondary employment. So if I wanted to work here 50 hours a week and work somewhere else 50 hours a week, I would have to approach you, Peter, because you're my boss, and ask your permission to do that, sign a policy. You would check whether that was a safe thing for me to do. You'd probably say no.
There's no probably.
So we have policies as well that prevent staff from working, because let's be honest, the drivers for working extra hours are quite varied. For some, it's just wanting to go the extra mile and the discretionary effort and give us what they can. For others, it may be financial. They may need to work more than full time, because that's about putting food on the tables. But lots of different ways in which we do it. Of course, finally, just to note that we also encourage people to let us know if they've got concern about a colleague who may appear to be overworking, not in the telltale space, but just so we can check in and make sure that that's okay.
And from a board perspective and from non-execs, I think this area is probably the one which has the most questions for assurance of execs, in terms of what are we doing to enable staff to work safely. We've got 2 minutes left, and one's just come in, which I'm going to ask, because it's about nurses from overseas. The COVID pandemic has recently overshadowed the looming Brexit issue. We have seen excellent European nurses leaving the UK and a huge reduction in European nurses coming into the NHS. What are we doing to ensure an adequate nursing training and recruitment pipeline post-Brexit?
Wow.
It's 2 minutes, Steve. No, I mean, it's just that we're doing so much in this area that I think it's worth a response.
Thank you, Peter. We're doing lots, and I'm really pleased that our international students have now started coming back into the UK. In fact, we welcomed some just a few weeks ago. We're also working with the University of Gloucestershire, and we've got a fantastic pipeline of registered nurses, but also nursing associates and also some AHP colleagues. So our pipeline for registered nurses is looking good. And in fact, just last month, we welcomed over 80 registered nurses and nursing associates into the organisation. It's the most we've ever had. And I can't tell you as chief nurse how excited I am that they've chosen us for their career. So we're looking forward to looking after them.
And Peter, probably just worth noting, because unlike many core cities, Birmingham, London, Bristol, we don't rely heavily on nurses from overseas, or indeed whether that be Europe or internationally. We welcome them when they want to join us, but we, unlike many trusts, that isn't something that we rely upon. And as Steve has just said, silver linings again, but I read something recently that enquiries into nursing as a future career have gone up 17% during the pandemic. Yeah, really delighted that what we've shown, the best side of ourselves as a result of the pandemic is leading people. And what's interesting, particularly, as I call them, second careerists. So people that have perhaps done a career are thinking about doing something else, and the language about wanting to give back, that thing around values and vocation coming really back to the fore again. So really delighted and looking forward to those becoming part of Gloucestershire Hospitals.
Great. No, thank you very much. So just as we wrap up, I did have a 30-minute closing speech. We'll leave that. I am very pleased that we've given much more time to questions than we've ever been able to do. So thank you for those who are who have answered. Thank you to all the presenters. Thank you to all the backstage people. And yeah, big round of applause for everybody. I think this has worked incredibly well. Thank you to everybody that's joined us this evening. And I just want to leave you with one last, it's not a question, it's a comment. Please may I take the opportunity to thank everyone at Gloucestershire Hospitals NHS Foundation Trust for all you do day after day, pre-COVID, during COVID and post-COVID. Thank you. And it's probably a good way to end. Thank you very much and good night, everybody.